Okay, good evening, everyone. So, welcome to our very first meeting for this year. So, before we start, let's place ourselves in the presence of the Lord. In the name of the Father, the Son, and the Holy Spirit. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speaker today of your greatest inspiration so that they may share the most of their knowledge, heart, and soul to their respective topic. May we absorb the invaluable knowledge and put it into practice what we may learn today. We pray that you bless all the committees in charge that they may be able to fulfill their task responsibly, that the objectives they have set may all be achieved. Your infinite blessing would mean the success of this activity. May we be the living witnesses of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of our Lord, our Savior. Amen.
Philippine Society of Diabetologists. The mission of PSD, the pursuit of excellence in diabetology. The vision of PSD, excellence in diabetology. Objective of PSD, to keep abreast of the most recent developments in all fields of diabetes research, education, and treatment. The PSD Statement of Purpose. The purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The purpose of PSD is to understand and accept that diabetes is a complex condition affecting an individual, the family, and community. Knowledge of its biomolecular and cellular origins and understanding all its interventions are as important as mastering its psychosocial dynamics. The purpose of PSD is to be a family of responsible persons bonded by one passion. Agreeing and disagreements strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. The purpose of PSD is to be a source of inspiration that informs, guides, and corrects one another in daily practice. We find happiness in sharing knowledge and experiences that improve patient lives. The purpose of PSD is to support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of effort. Collaboration drives inspiration, motivation, and creativity. The purpose of PSD is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision will evolve with time, but the family lives on.
Okay, just to introduce to you the PSD Board of Directors for the next 2 years. We have Dr. Valdemar as President, Dr. Marcy Cruz, your Vice President, our Secretary, Dr. Fatma Chu, our Treasurer, Dr. Jamin Agra, and our Auditor, Dr. Rocky Disa, and our immediate past President, Dr. Elwin Fernando. So we would like to welcome everyone. Kung Hey Patchoy Advance. So kaya napapanahon din kasi na-miss natin itong ating speaker. So we are very grateful to LRI Terepharma for the CME grant. So let us start the ball rolling. So thank you, LRI Terepharma. Okay, let me introduce our distinguished speaker. She is the immediate past president of Diabetes Philippines and the past president of the Philippine Society of Diabetologists. She is our ISDFI Assistant Director for the Education Unit as well as the faculty of the ISDFI. Presently, she is the Director of Medical Education, Chief of Clinics, and an active consultant at the Metropolitan Medical Center. So napakaswerte natin ngayon kasi siya yung magbubuena mano ngayong 2022. Okay? So ating minamahal, si Dr. Grace de los Santos. Welcome po, ma'am.
Hello, Danny. Thank you. Sana hindi ako pumalpak ngayon sa pag-share ng aking slide. Thank you. Thank you, LRI, for the invitation. Na-miss ko na rin kayo. Gusto ko na nga mag-face-to-face dyan. Let me just share.
Wag mo na, ma'am. High risk ka.
Ha? Okay
High
na yun?
risk ka. Magpahinga ka
Marami
lang.
na akong antibody. Nag-booster na ako. Nag-positive pa ako. Marami na akong ano.
Yeah.
Pero hindi ka rin sigurado eh. So, ano lang. Okay na? Oh, hindi
Yes.
ako pumalpak. Salamat sa Diyos. Okay, I'm so happy to see you. Sana mag-appear kayo lahat. I-open nyo yung video mamaya para makita ko naman yung mga mukha ninyo. This is my disclosure. So we'll be talking about diabetes and cardiovascular disease. Ang mga first few slides, tinanggal ko kasi we were about the history of sugar. Alam naman natin na ang sugar intake can lead to diabetes. We had discussed this in the masteral class earlier. Nagtanong, ang asukal ba talaga pag sumobra ka, nakaka-diabetes? Totoo yun. Kasi it will lead to your insulin resistance, your obesity, your insulin resistance, and then fatty liver, and then eventually leading to your diabetes. So we will not be discussing about the sugar, but rather we'll be discussing how to treat the cardiovascular disease related to diabetes. So we'll just look at the cardiovascular continuum. I know I'm not in parang hindi ako specialista dyan, pero we'll be talking about the diabetes problem in the cardiovascular continuum. And then looking at the pharmacologic options in diabetes care plus the heart failure, which is usually the end stage of our cardiovascular disease. This one is, we know that by 2045, from 2019, okay, that there will be a 51% increase in the prevalence of diabetes mellitus worldwide. And in the Philippines in 2014, we have 3.2 million of Filipinos suffering from diabetes. And there are around 53,000 and a half, okay, 53,500 deaths reported to be due to diabetes mellitus and its complication. Sorry. At ayaw na mag-move. Okay, and we know that in 2017, the registered death in the Philippines listed diabetes as the number 5 top cause of death among the Filipinos. However, we know very well, yung first one is ischemic heart disease, and the third one was cerebrovascular disease. And this may be due to your diabetes. And we know that most of our diabetic patients died of cardiovascular disease, okay, or renal disease. And you can see from this list that there was no mention of kidney disease, which is also very prevalent among the Filipino people. And the diabetes being the most common cause of renal chronic kidney disease among the Filipinos, okay, is well known. So the diabetic patients usually may die of diabetes-related complications. However, in the death certificate, we don't usually see diabetes as the cause of death, but rather we see that the cause of death is due to the cardiovascular, cerebrovascular, or electrolyte imbalance or acid-base imbalance, yung mga ganun na problema. So the listing of diabetes mellitus as the fifth cause of death among the Filipino people may not be that accurate. And in 2017, it was reported that there were already 50,000 of diabetic Filipinos died due to the diabetes-related complications of cardiovascular, your cerebrovascular, and renal failure, plus your heart failure. So recently, we know that before we don't talk much about heart failure. Minsan na-discuss natin few years ago about cardiomyopathy, specific type of heart failure secondary to diabetes talaga, and it is being diagnosed by ruling out other causes of heart failure. So, yung diabetic cardiomyopathy, yung discuss natin, parang ano ba yan? Okay? What is it? But we had it like one lecture, we had that discussed during our PSD, our annual, okay? During our PSD annual meeting. So, ang inaano natin ngayon is, ang heart failure ngayon because of the many new diabetic medications that shows that it was beneficial to prevent death, mortality from heart failure, na medyo ngayon, nare-recognize na rin natin yung heart failure problem among our type 2 diabetic patients. And among the Asian registry, the top 3 causes of your heart failure, the prevalence of heart failure is due to your hypertension, diabetes, or coronary artery disease. And you can see, comparing the different regions of Asia, that Southeast Asian had the most number of patients suffering from your heart failure problem. And having the heart failure problem, even among the Filipinos, 16 cases of heart failure had been recorded for every 1,000 patients claimed from PhilHealth. Now, the problem of heart failure is it increases the mortality rate, especially among the diabetics. And also, there is the higher rate of rehospitalization and poorer quality of life, and the in-hospital mortality is rather high. And from the, even among our data, that hypertension is the most common cause of your heart failure, congestive heart failure problem. So looking at the continuum, okay, we can see that hypertension, dyslipidemias, and diabetes are considered to be risk factors, and I think insulin resistance or hyperinsulinism is also considered to be one of the risk factors for your heart disease, ending in heart failure, leading to end-stage heart disease, leading to the demise of the individual. However, among our type 2 diabetic patients, we may not develop the entire continuum of the heart failure or heart disease, but rather we may jump from the risk factor of diabetes going directly to your heart failure problem because of the microvascular complication or involvement in the small vessels of our heart, okay? And that's your diabetic cardiomyopathy. We don't go through the atherosclerotic process, and usually for the diabetic cardiomyopathy, usually when you do their coronary angiogram, they look very clean. The big vessels look very clean. It's a small vessel disease, which is typical of our diabetic cardiomyopathy. And because of that, we know that a heart failure could be secondary to ischemic cardiomyopathy or to the non-ischemic cardiomyopathy due to the deposition of fat, then leading to the formation of fibrosis, leading to heart failure, diastolic first, diastolic heart failure, or diastolic dysfunction, and then the second stage is already your systolic dysfunction. So we have to look into that because during the earlier stage with the fatty cardiomyocytes, we may be able to reverse the process of the diabetic cardiomyopathy by addressing the risk factors, especially considering the medications that are useful or that can address the problem of the other risk factors like your hypertension or dyslipidemias, and those medication should not be should not cause more problem with our glycemic control. So in our choice of medications, in the treatment of the heart problem of our diabetic patients, we choose medications that will be beneficial also, if not, basta not harmful, but if there's beneficial effect on our patients, we would like to choose them. Now, because of these two problems, both ischemic and the small vessel disease causing the heart failure and diabetes, we have also, aside from hyperglycemia, we have also the insulin resistant state, okay, the hyperinsulinemia itself. These two conditions can also lead to atherosclerotic process. They can cause inflammation, okay, they can start your endothelial dysfunction, leading to your atherosclerotic process, leading to ischemic type of cardiomyopathy. Furthermore, because of the fibrosis, okay, because of the RAS activation, okay, causing your hypertrophy, left ventricular hypertrophy, okay, and also because of the calcium handling, mishandling of calcium, the cardiomyocytes, there is the changes of the metabolites used in the metabolism of cardiac muscles, okay, and also problems with the autonomic dysfunction secondary to your diabetes. All of that may lead to your diabetic cardiomyopathy. Hence, the heart failure risk is about 2 to 5 times higher among the diabetics compared to the non-diabetics. And if a diabetic patients, okay, develop heart failure, okay, 32.7, there's a mortality rate of 32.7 per 100 persons here, okay, than comparing the diabetic patients without heart failure. So the presence of heart failure among our diabetic patients will confer a higher mortality rate among them. Simply because the hyperglycemia will begets heart failure, and the heart failure may induce insulin resistance, okay, and develop diabetes mellitus. So it shows that with hyperglycemia, and then there is heart failure problem. On top of it, you have problem with energy metabolism of the cardiomyocytes. When there is that, with the cardiomyopathy, you increase the inflammatory reaction, and this may induce the development of diabetes mellitus also. Now, when we treat our diabetic patients, it's not just controlling their sugar, okay? If we over control the sugar, there is also a higher risk of mortality from your heart failure. So there's a J shape, okay? If your A1C is above, okay, is higher, not controlled, or your over control, when patients develop hypoglycemia, both high and lows of your blood sugar may induce the process of atherosclerosis. Okay, with the low, you have the inflammatory cytokines being produced. With the high, the same way. Okay, so we do not want patients to suffer also from hypoglycemia, because that frequent hypoglycemia can also induce atherosclerotic process among our diabetic patients. So how do we address the problem of heart failure, knowing that diabetic patients have a higher chance of developing heart failure from ischemic process or from the small vessel problem? So how do we address them? There are 5 pillars. Okay, just like oftentimes in the first stage of the cardiomyopathy, we manage them. It's called the PEF, the preserved ejection fraction. And usually when you look at these patients, when you take their 2D echo, you can see that the ejection fraction may be at the level of 80s, 90s, okay? And yet there is already mentioning of the diastolic dysfunction. So there is impaired relaxation because of the deposition of fats in the cardiomyocytes. And this fat deposition will induce inflammatory changes, and the inflammatory changes may lead to fibrosis of your cardiac muscles. So this is the way, and then when that happens, initially it starts with impaired relaxation, and then with the stage 2, there will be already impaired systolic function. And oftentimes, during the stage 2 development of our cardiomyopathy, we may not be able to reverse it back to normal, okay, because of the presence of the fibrosis, pathologically presence of fibrosis in the cardiomyocytes of our individuals. Okay, so in the management of heart failure from any cause, okay, you have the use of your ACE inhibitors or angiotensin receptor blockers, ARBs, okay, or the ARNI, the angiotensin receptor nephrolysin inhibitor. Okay, these are the new ones, which is very expensive. Now we will talk about each of these arms separately, why it's being used and how it is being used. Then we have the beta blockers that has been proven to help our heart failure patients, okay? Because with the problem, there is already increase in your adrenergic activity, and we don't want that to happen. The patients will experience higher heart rate, okay? We don't want that because that will be more taxing to the cardiac function. Okay, so, but not all the beta blockers are used for our diabetic patients because some of these blockers may also cause inhibition of your insulin secretion. So there are some beta blockers that are friendly to the diabetic patients. Then we have the mineralocorticoid receptor antagonist. Okay, so we have the spironolactone, okay, that we may help use because of the increased RAS activity. Then there is increased also aldosterone formation, production. Then recently, in the last decade of our practice, okay, in the last decade, we have the discovery of your SGLT2 inhibitors that were found to have much beneficial effect among the cardiac disease, okay, patients with cardiovascular disease and also patients with renal problem. Okay, so and now it's being advised or being recommended for patients even without diabetes. Okay, if they have the problem of heart failure or kidney, especially the kidney disease, chronic kidney disease, SGLT2 had been recommended for your management, okay? Because all of them, I think 2 out of the 3 had already released their CKD study. The other one is undergoing. When both of them, the one that had been published, had shown much beneficial effect on the kidney function. And then lastly, we have the metabolic modulators because we know that the metabolism or the fuel requirement for the contraction of our cardiac muscles all depends upon the nutrient that is being fed to the cardiomyocytes. So let's first look at the ACE inhibitors or the RAS blockers. Okay, we know that angiotensin 2 plays a central role in our organ damage. Okay, with the attachment of the angiotensin 2 to AT1 receptor, we have AT1 and the AT2 receptors. It will lead to the endothelial dysfunction, initiate endothelial dysfunction, leading to vascular hypertrophy, causing vasoconstriction, and eventually leading to your atherosclerotic process. So we have the end product of your stroke and then death or heart failure, MI, death, also leading to death, and also it may also affect your microvasculature of your kidney, causing renal failure. Now in the heart, okay, it induces left ventricular hypertrophy. It may involve the formation of fibrosis, transforming the fibrosis. Left ventricular hypertrophy because of the involvement of your intima media. Okay, there is a muscle dislocation. Okay, there is a plaque formation, there is cardiac remodeling, and also cardiac muscles death, apoptosis. For the kidney, it may cause proteinuria and increase in your aldosterone release, increasing your glomerular sclerosis. So angiotensin to actually play a very central role in the organ damage. And looking at the entire continuum of the cardiovascular disease, RAS activation is involved in all the process, okay, from the risk factors, okay, to your atherosclerotic process, to myocardial infarction, to even heart failure. So there are two angiotensin receptors, okay? We have the AT1, which is the bad one, and AT2, which is the better one. So if you want to give the ACE inhibitors or the ARBs, especially the ARBs, we would like to block the AT1 receptor. Okay, because AT1 receptor is the one that's responsible for the vasoconstriction, sodium retention, sympathetic nervous system activation, inflammation, and it has growth promoting effect, okay, and apoptosis. However, with the AT2, if you block the AT1, then you may have the vasodilatation, natriuresis, okay, the opposite effect of your AT1 activation, AT1 receptor activation. So with the ACE inhibitor, you block the kinin, okay. With the ARB, you don't block the kinin, okay. And with the ARBs, we block the other ACE-independent angiotensin for angiotensin formation by the kinase in other enzyme system. So, if we block the RAS system, which is one of the mainstay when we treat our hypertension, we treat our patient with cardiovascular disease or even renal disease, okay, if we block them, we improve the endothelial function, we decrease the oxidative stress, which is the substance, okay, or the things that will cause all the complications of diabetes and even the deterioration of our beta cells function. We also decrease the inflammatory reactions and also decreasing the tissue remodeling. And clinical studies have shown that with many of the ACE inhibitors or the ARBs, okay, that it has been used for heart failure, post-MI, diabetic patients, nephropathy patients, hypertension, and all of this, okay, shows beneficial effect. And that's the reason why for our diabetic patients with some proteinuria, or even with hypertension without proteinuria, the first drug of choice for the hypertension is usually an ARB or an ACE inhibitor, so a RAS blockers. And for patients with microalbuminuria already, okay, some renal damage already, then again, ACE inhibitors or ARB is also recommended, even if they are not hypertensive, provided it doesn't cause hypotension. So all of these studies have shown significant improvement in patients with congestive heart failure following an MI or a chronic renal disease. And we know that there is such a thing as metabolic cardiorenal triad. Okay, so the three comes together because at any stage of your renal insufficiency, there is a corresponding change in our cardiac function. So the two actually go together, and we have heard a lot of lectures about the cardiorenal syndrome. So let's narrow down to, since our sponsor, they have their own ARB, okay? They have the candesartan, okay, in 8 and 16 milligrams, and it was also co-administered or in one tablet, your candesartan with your hydrochlorothiazide. So let's narrow down to the study of candesartan in heart failure assessment, okay, taking into the looking at the endpoint of your cardiovascular death or heart failure pre-hospitalization. Okay, so they have the three components. It's a program, okay, composing of three studies. One is charm alternative, meaning patients who cannot tolerate ACE inhibitors, okay, they will shift to the candesartan, okay, and they are those with reduced ejection fraction heart failure, so left ventricular ejection fraction of less than 40. And the other one, the charm added, is the one patients were already on ACE inhibitor and the standard care for heart failure, the standard care for heart failure, and they added the candesartan. Okay, and the last one is the preserved, and as the name implied, okay, the left ventricular ejection fraction is more than 40%. So these are the cutoff point usually for studying for the preserved and the reduced ejection fraction is 40%. Even with the studies for the SGLT2, this is the number that they use also, 40%. If it is below 40, then they call it the reduced ejection fraction, so HEPREF. And if it is above 40, they call it the HEPREF, preserved ejection fraction. Okay, whether they are treated with ACE inhibitors or not treated with ACE inhibitors. Now you'll notice that in charm added and the charm preserved, in charm added, definitely everybody was on ACE inhibitor, and then the ARB, the candesartan, is added on top of it. And the preserved, even if they are on ACE inhibitor, then candesartan is given also. But we know nowadays that the nephrologists don't advise the concomitant use of ARB and ACE inhibitors because of fear of acute kidney injury. Okay, they're afraid that there will be too much vasoconstriction, okay, and there will be too much lowering of your EGFR. So, but in this particular two studies, there were no reported acute renal injury on these particular two studies being added, an ARB being added to an ACE inhibitor. Now, each of these trials, the key outcome is looking at the cardiovascular death or heart failure hospitalization. And the secondary outcome, they want to look at other cause of CV outcome, okay, the death, cardiovascular death, okay, and the mortality in patients with reduced ejection fraction. Other pre-specified outcome, they want to look at development of diabetes mellitus, noting that many of our patients, okay, aside from hypertension, may also have diabetes or may have family history of diabetes or may have features of insulin resistance, and they would like to know if candesartan has any effect on the development of new onset diabetes, okay, and other outcomes that may be reported by the investigators. They included patients with the New York Heart Association class 2, 3, and 4. They did not include the class 1. And many of the patients had already a post-myocardial infarction. Okay, they have hypertension and some have atrial fibrillation, and diabetes is around 27 to 30% of our patients enrolled in the 3 studies. Okay, and when they look at the development of new diabetes, it seems that candesartan fare better with a significant reduction or delay in the development of new diabetes by 40%. So the PRESERVE trial the CHARM trials provide the supportive evidence that the ARB candesartan can prevent heart failure hospitalization and can prevent the development of diabetes. And the PRESERVE, CHARM PRESERVE is the 3rd study looking at patients with ejection fraction of more than 40%. There is a reduction of your all-cause death, although not significant, but it just touches the confidence interval of 1. Tumama lang siya doon, kaya hindi siya naging significant. But you can see from the graph that they have lowered. Okay? And for the cardiovascular death and congestive heart failure, the primary outcome, there is a significant reduction of about 16%. And looking at this plot, okay, regardless of age, okay, it benefits mainly significant for the older individuals. For less than 65 years of age, it crosses the line of unity. And also for preserve ejection fraction, it crosses also the line of unity. But for the reduced or less than 40% ejection fraction, it benefited them more. Okay? And we can see that it benefit also all class of their, based on the class of their heart failure, the New York Heart Association classification, it benefit both it from class 2 to class 4. So overall, it shows benefit as far as the hospitalization for heart failure and also the cardiovascular death. It is significantly beneficial. So the conclusion of the CHARM program, okay, treating a broad spectrum of patients, both symptomatic or the reserved ejection fraction, there is a significant reduction in the hospitalization for heart failure by as much as 21%, a 16% reduction in the cardiovascular death or heart failure hospitalization, the primary outcome. There is a lowering, okay, or tendency of reduction of 12% in cardiovascular mortality, although not significant, and a 9% reduction in all-cause death, not significant, but there is a tendency toward a reduction. So from the CHARM program, the addition, the implications, it implies that the addition of ARB, okay, candesartan in particular, can be considered in all patients with chronic heart failure, irrespective of their ejection fraction, age, or sex, and also irrespective of the treatment they are receiving, even given on top of your ACE inhibitors. Okay, but as I told you earlier, they don't recommend giving the two together. Okay, but I've heard some nephrologists doing that. Okay, just be very cautious. Okay, and follow these patients up very frequently. And that was what I learned from some of the nephrologist lecturer. So candesartan can treat hypertension, lower hypertension, at the same time can be used for patients at all stages of their heart failure. Now let's go to the beta blockers. With the heart failure, you increase your adrenergic activity, increasing the cardiac beta adrenergic receptor, so increasing your heart rate and contractility, and making your heart failure worse. Okay, trying to improve the cardiac output, but it may cause eventually aggravation of their heart failure status. So it may cause aggravation of the disease, especially if this is due to the ischemic heart failure, okay, and it may cause arrhythmia, okay, because of the increased activation of your adrenergic receptors. So beta blocker is central in the management of patients with heart failure with reduced ejection fraction. And the meta-analysis support the prognostic benefits of your beta blockade in heart failure patients, especially among the diabetic patients. Carvedilol being one, as I told you earlier, not all beta blockers have that kind of benefit. The carvedilol is a combined beta-1 and beta-2 antagonist. It improves both glycemic control, the heart failure status, and decreases oxidative stress in the failing heart, human heart, and might be the beta blockers of choice. And contemporary clinical guidelines support the use of beta blockade in patients with diabetes mellitus and heart failure. Before, we used to think that beta blockade is bad for our diabetic patients because it will inhibit the secretion of your insulin because of its blockade. However, and also it may block the symptoms that may be triggered by hypoglycemia. So there may be hypoglycemia unawareness. However, with the newer beta blockers from the studies, it shows that it does not increase the problem of hyperglycemia. Okay, and one of the beta blockers that is being mentioned is your talvedilol. Okay, in the Copernicus study, which is the alvedilol used in severe heart failure patient, it shows that there is a 34% decrease in mortality, 27% in hospital stay, so there is less, okay, hospital stay for any cause, and the number of days spent in the hospital for the heart failure was decreased by 40%. Now, when you have heart failure, usually it's a very the it it is a economic burden aside from the poorer quality of life. It has a economic burden for the family. Okay, for the family. So we have to choose a medicine also that we want to use for your because the beta blockade may further complicate our problem of heart failure. Okay, and among our patients with diabetes that were included in the study, they seems to benefit more than those without diabetes. Okay, and compare it to your metoprolol, the COMET study, it shows that the mortality is lessened. Okay, compared to your metoprolol, both of them are considered to be beta blockers. The old metoprolol and the newer talvedilol. So talvedilol can also be used in patients suffering from heart failure safely, and also it can reduce your hypertension, uh, and also it does not increase the incidence of hyperglycemia in patients. Now the last one is your metabolism of your cardiomyocytes. The cardiomyocytes function, okay, the contraction of your cardiomyocytes depends on the production of the ATPs. And the nutrients for the cardiomyocytes comes from your glucose as well as your fatty acid. About 60 to 70%, up to 80% of the requirement of nutrient for the cardiomyocytes will be coming for the fatty acids because after 4 or 5 hours in the post-absorptive state, glucose is no longer available, okay, to support the function of your heart. And our heart is 24/7 had to contract. So they have to depend on your fatty acid, okay? So with that, what happened was, in the presence of hyperglycemia among our type 2 diabetic patients, in the presence of hyperglycemia, it will favor more so with the fatty acids. There will be blockade of the insulin resistance. There will be blockade of your glucose being used by your cardiac muscles. And what is the implication here? If you use glucose as a source of your production of your ATPs, it will use less of the oxygen molecules. While if you use fatty acids or the fat, okay, for the production of ATPs, you will have to require more molecules of your oxygen to produce the same amount of ATPs. So it is more costly to use your fatty acids, okay, as a source of your ATPs rather than your glucose. So in a failing heart, in an ischemic heart, then more so you want to preserve the oxygen supply of your cardiomyocytes. So when you use something, when the fatty acid oxidation is being favored, there is one substance, okay, the trimetazidine, that can block the entry of your final entry of your acetyl-CoA to the Krebs cycle, producing your ATPs. Okay, so it is at this stage, okay, before or immediately after the formation of acetyl-CoA, before it enters your Krebs cycle, there is an enzyme here called the thiolase enzyme. Now, trimetazidine is the one that blocks the thiolase enzyme. So once it is blocked, then you will favor the entry of your glucose to provide, okay, to the pyruvate to enter the Krebs cycle to produce your ATPs. And as I said earlier, you use less oxygen molecules to produce more equal amount of ATPs compared to your fatty acid oxidation run with your glycolysis process. Okay, so using the sugar, favoring the oxidation of your sugar or the glycolysis process for your ATPs production, do it like that, especially in ischemic heart. And studies have shown that cardiac metabolism as a target for your treatment of heart failure has been successful using your trimetazidine. And in the new 2016 European Guidelines on Heart Failure, but the trimetazidine has been recommended in heart failure to shift the myocardial energy metabolism from fatty acid beta oxidation towards your glucose oxidation. It has shown improvement in the endothelial function, a reduction in the calcium overload and free radicals induced injury. And the free radicals we know is the one that is causing all the troubles in the heart, also in the among the diabetics, in our even in our beta cells, okay, the endothelium, okay. Everything is about whether it's lipotoxicity, glucotoxicity, all ends up with inducement or increase in your oxygen radicals, causing oxidative stress. There is inhibition of cell apoptosis, and also there is preserved myocardial high energy phosphate levels in patients with heart failure, and it provides a significant improvement in the functional class and left ventricular function in heart failure patients. It has been shown to improve exercise duration, left ventricular function, and quality of life in patients with heart failure. Once the heart failure symptoms disappear, the patient's quality of life will usually improve, okay, especially in those patients with reduced ejection fraction. It also improves the skeletal muscle metabolism, but I asked one of the company that product that has the product, okay, if they have any study on skeletal muscle metabolism, because noting that the skeletal muscles also uses fatty acid oxidation and also glucose oxidation. So, and we know for a fact that among our type 2 diabetic patients, they tire easily. They cannot have the same duration of exercise compared to the non-diabetics, okay, because the muscles actually doesn't function very well. So does it have the same mechanism of improvement of your skeletal muscle metabolism? The answer is not sure. So she will ask their medical liaison officer. And it prevents the cardiovascular event and hospitalization in patients with heart failure with reduced ejection fraction. So trimetazidine has been found to be an effective and safe anti-anginal. Actually, if you use it for anginal patients, the first thing that we'll note is they have less number of chest pain, less frequency of chest pain, and they have less use of their nitrates. Okay, studies have shown that. Okay, it's a safe anti-anginal treatment in patients with angina and also heart failure. It has been used safely in different conditions and in patients with multiple comorbidities. Okay, and it has little drug-to-drug interaction. And in the Philippine FDA, it has approved for modulation of cardiac metabolism. It has been approved for as an adjunct therapy for your patients with heart failure and angina pectoris. So through the years, we have mentioned earlier that we have more medicine, especially for our diabetic patients or non-diabetic patients. The SGLT2 inhibitors and the GLP-1 receptor agonists, that has been shown that the SGLT2 has more benefits, especially when there is heart failure problem already. Aside from before, we have the ARB as evidence from your CHARM study and the beta blockade with your calvedilol. So we can see the whole spectrum of our whole spectrum or continuum of our myocardial disease. It can be taken care of, and trimetazidine, tandesartan, and calvedilol, okay, can be used at any stage of the myocardial continuum, okay, from the risk factors presentation up to the heart failure problem. So I think that was my last slide. So we may have to have a choice, okay, for our diabetic patients, something that for our hypertensive diabetic patients, controlling the hypertension, but not increasing the problem of diabetes, or for some pre-diabetes, not enhancing them to become diabetic because of those medications. Okay, so for the control of hypertension, we know that usually we will have combined therapy, okay, that is the recommended. So both your tandesartan, your calvedilol may do the job, okay, and especially for patients, our patients with autonomic cardiovascular problem, okay, they will usually have fixed tachycardia, so beta blockers may be in order, okay? So we have a choice for patients with diabetes with comorbid conditions, especially your hypertension. I think I also I know that for a fact that for my patients on calvedilol, I didn't see any problem with the deterioration or worsening of their lipid status. We have to individualize our therapy, okay, and the adverse effect of our patients of our hyperglycemic medications, okay, combining with our hyperglycemic medications, we don't want drug-to-drug interactions. And also, we would like to look at the needs of our patients, especially their resource, okay, for buying medication. So with that, I'd like to thank you for the attention. Thank you.
Thank you. Thank you po, Mama Grace.
Yeah.
So, thank you very much sa ating sponsor din from LRI. So, if you have any questions for Mama Grace's presentation, you may type it in our chat box. Okay? So, nakakatuwa, Ma'am, ano?
Review lang kayo. Review lang sa inyo yan.
Oo nga, pero nakakatuwa. Naalala ko tuloy nung nag-aaral pa ako sa FEU, nung ano yan, clerk o intern o nung resident. Kasi di ba pagka nagda-diagnose tayo ng heart failure, kukunan mo pa yung kukunan mo pa siya ng yung pulse pressure. Tapos yung pipindutin mo yung liver para makita mo kung may distension. Tapos kailangan naka 45 degrees yung patient. Kukuha ka pa ng ruler para malaman mo na nag-heart failure siya. Pero ngayon, sa tingin ko,
alam mo, Danny, nawala na lahat yun.
Ayun na nga po sasabihin ko, ma'am.
Mag-order ng ProBNP.
Yun na yung mga residents natin. Nabawasan talaga. Oo, ma'am. Kasi na more on ang tawag dito, yung mga laboratory, yung mga technical na kailangan na ginagawa nila para to diagnose a patient. Pero yung sinasabi ko nga sa mga ibang residents, ma'am, paano kung wala kayong ganyan sa lugar nyo? Hindi nyo na alam kung paano ma-diagnose kung nag-heart failure yung patient. Ayun, mga JVP pala. Minsan i-refer pa natin sa surgery para kabitan sila ng
nagre-report sila ng JDD, pero hindi naman nila tinitignan.
Ma'am. Yun nga din, pati yung mga surgery siguro di na rin masyadong marunong sa mag-cut
Malinaw.
down na mag-cut down sila. So, isa
Masyado
yun
na
sa mga
specialized. Pero in
ano pa?
in diabetic cardiomyopathy, it's very difficult to do it clinically. Kasi usually wala. Tapos
Ah,
lumalabas na lang yon pag meron silang septicemia, yung may problema na, biglang magka-heart failure, biglang magkakaroon ng pleural effusion because of the heart failure. Pero pag tinikman mo yung kanilang echo, maganda pa rin ang kanilang ejection fraction sa totoo lang. Pero
ayun, ma'am.
meron na nakasulat, impaired relaxation. Impaired
Opo.
left ventricular relaxation. Yun ang stage na pwede natin palitan, yung baguhin, na ibalik sa dati. Pag nagsystolic na, fibrosis na yun, wala na tayong magagawa. Yun ang may symptoms na konti.
Ayan, tama yan, ma'am. Yan nga yung nakikita natin. Kaya isa dyan yung tanong ko sa inyo, ma'am. If you are going to request na yung routinely na yung mga patients with diabetes, especially yung mga long-standing diabetic natin na may hypertension, naggagawa ka ba, ma'am, routinely ng 2D echo?
Ordinarily, pag walang symptoms, usually hindi. Pero pag for surgery, like patients like elderly, mga more than 60, kahit na walang symptoms, mas safe ako kasi pwede sila mag-heart failure during the surgery if it is a major surgery. Pag minor, hindi.
Pero yung iba natin din, ma'am, na asymptomatic patients, halimbawa yung meron kasi mga nakikita din ako, asymptomatic sila, routine lang kasi gusto nilang magpa general exam, tapos gusto nilang natutundi echo din sila. Tapos pag lumabas yung result, makikita na meron na rin silang ejection, relaxation
Grade 1.
problem.
Grade 1,
May
usually
LV.
mentioned. Grade 1,
Yes.
diastolic dysfunction. Yun ang mga term na ginagamit.
Yes,
So pag
ma'am.
pumunta sila sa cardiologist, pag nakita nila, hindi pinapansin. Sa totoo lang.
Oh. Actually, wala naman din talang binibigay na gamot, ma'am.
Wala,
Pero kung mga hypertensive sila, then they usually start din naman na po sa mga
RAS.
ARBs and ACE inhibitors. So, maganda rin yung na-review ni ma'am yung pathophysiology of heart failure, and she did show us the benefits of your candesartan, your beta blocker, and your trimetazidine sa mga pasyente natin na may heart failure. May tanong lang po ako, ma'am. Yung candesartan, ano po yung advantage niya uli po with regards to the other ARBs?
Okay. Lahat ng ARB, nakakaganda sa puso, right? Lahat yan meron. Pero ang tanging isa lang, it is long-acting, una. Okay, it has a 36 hours. So, pag nakalimutan mong uminom ng umaga, pwede mo pa habulin ng gabi. Although we know that the ARB, they work better, the RAS system is more active sa night. Kaya sa mga short-acting, like yung losartan, the short-acting, we usually will give it at night.
Mm-hmm.
And then we usually will check. We would like to have a 24 hours control of the blood pressure. Alam mo naman yung search sa umaga, hindi ba? So usually
Yes.
I advise my patient to check their blood pressure upon waking up, na hindi pa sila umiinom if they are taking it in the morning. Dapat sa umaga, hindi pa siya umiinom ng gamot, dapat maganda pa rin ang blood pressure niya. So candesartan is one of the long-acting. Tapos, CHARM study, kahit na dinagdag pa nila sa ACE inhibitor, which is not recommended, binibigyan pa rin. So, wala naman sila nakitang acute kidney injury. Tapos,
ma'am,
sige, go ahead.
Ay, sige po.
Hindi, meron pa isa na siguro magandang i-share sa atin. Alam mo ba, sige, magtanong na ako, tutal kapamilya naman kayo. Mga kapamilya, mga anak, ano pang advantage ng candesartan na alam ninyo na hindi alam ng LRI? Ng blow press, yung kahit na blow press, yung original, hindi rin nila alam. Pero meron siyang advantage, meron siyang 3 studies.
Yan ang hindi ko rin alam
lulutuan
yan,
ko kayo
ma'am.
ng pagkain. Kung sino nakakaalam, lulutuan ko kayo ng pagkain. Sige.
Any volunteers? Ay, nako, si
Anak ko
Pay
ang
naman ang
sumagot. Lulutuan na lang kita anak dito sa bahay. It is about the retinopathy. Okay? 40% reduction of the onset or initiation of your diabetic retinopathy. So maganda yun. So maliban dun sa hindi nag-i-increase ng hyperglycemia or new onset diabetes, marami naman sila sa ARB na ganun ang nakikita nila, di ba? May sa losartan, meron din sila. Okay, so meron sila talaga, mukhang class effect naman yung mukhang class effect. Pero siya lang ang may study sa retinopathy, actually. 40% reduction in the onset of retinopathy.
Yeah, dapat lahat ng mga patient natin with diabetes, maganda ma-screen for DM retinopathy.
Ito naman tinuturo natin.
Kaya nga po ma'am, kaya dapat lahat yan ha.
Ginagawa yan, oo.
Eh ma'am,
type 2.
Yung candesartan po ba, dose dependent, yung protection niya sa heart failure, yung benefit niya sa heart failure? Kasi I've seen mga cardiologists,
ayaw mo rin umakyat, 8 and 16
yung 8 mg hahatiin pa eh.
Ha? Siguro
Merong
pag na-hypotension, ayaw natin ng hypotension.
Especially kasi meron din mga nagka-heart failure na normal yung blood pressure.
For those, probably I will use the shorter acting. Mas takot ako mag-hypotension kasi mas nakakagrabe ng problema. So probably I'll shift them to a shorter acting or a talagang very short acting like your, ano ba yung unang
Losartan.
Captopril. Captopril.
Captopril.
Yung pinaka-shortest acting, Capoten before.
Yes.
I will usually start with that kung pag normo siya. Pag hindi siya, pag umubo siya, then I will shift it to a slower, shorter acting, which is your losartan. Kaya pag magbibigay ka ng losartan, dapat gabi. Or twice a day. Kung hindi makontrol sa morning. Kung yun lang ang monotherapy mo sa hypertension. Kung walang pera, kasi lang binibigay na libre.
Opo, pati sa center. Libre na rin siya. Kasama ng metformin. Ma'am, yung, di ba, inflammation yung problem sa hypertension, sa diabetes. Yung sa candesartan, paano po niya magkakaroon ng effect?
Hindi ko masyado na-review yun. Pero naman na-mention, ang na-review ko lang yung sa mata, kasi nung minsan nag-lecture na ako nito. Yung binigay sa akin na articles, yung sa mata, pero hindi nila alam yun. Binigay lang sa akin.
Kasi kung sa mata, baka inflammation din na po.
Lagay ko. Sa angiopathies din. Sa mga blood vessels. Sa mga blood vessels. Hindi ko alam ang sagot mo. Pero meron daw silang anti-inflammatory. Di ba? Diabetes is an inflammatory disease.
Yes po.
Atherosclerosis is also inflammation.
Kaya baka napapababa niya rin yung mga inflammatory markers natin.
Siguro, sige, examining ko. Magbabasa ulit ako.
Thank you po. So, do you have any questions pa? Ito pa mo. Aside from improving the cardiac function, is there a role of your trimetazidine in improving the fatty liver naman?
Wala. Wala siyang study on that. Wala siyang study on that. Yung trimetazidine, wala.
Ito ma'am yung kanina pinag-usapan natin yung cardiac remodeling sa findings natin sa mga pasyente with 2D echo. So sabi nga natin, kahit maganda pa yung ejection fraction, tapos asymptomatic yung patient, recommended to reverse remodeling kung mag-i-start na agad din tayo ng mga ARBs sa patients nito.
Kaya di ba yun ang first medicine recommended?
Yeah.
Di ba? Sa mga diabetic, kasi may hypertension, may proteinuria, kahit na walang hypertension, ibibigay natin ARB. Pero kung walang hypertension, walang proteinuria, walang ARB. Hindi basta-basta binibigay ng parang prophylaxis. So dapat
importante
hypertension, importante may hypertension is actually indicated for hypertension or proteinuria. Yung dalawa.
Okay. Kaya yung importante
walang hypertension. Just because you have hypotension.
Kaya dapat i-check nyo mabuti rin, mag-request po kayo ng mga urinalysis para ma-check nyo kung meron na talaga silang proteinuria.
Microproteinuria, microalbuminuria. Ang
Micro-
recommended ngayon is urinary albumin creatinine ratio. Pero pag wala dun sa lugar ninyo, mas mahal din yun, pwede kayo mag-request ng micro test, which is less
Yes.
expensive and
Micro
more
at
readily
saka, ma'am,
available.
yung Diabetes Philippines, meron silang program dito
Oo,
for yung
Act
ACT,
now.
yes.
Yeah.
Para yung mga pasyente natin kahit hindi nila ma-afford yung UACR din, pwede po yun micro test.
Kung may
Okay?
mga pasyente kayo, kung marami kayong pasyente na hindi ma-afford na magpa-check, pwede kayo tumawag sa Diabetes Philippines. In cooperation with Astra.
Yeah. So we can find ways para matulungan natin yung mga pasyente natin.
Oo.
Any more questions? So, ma'am, any last message po for our kapamilya?
Like what our mentor had taught us, prevention. Huwag na nating hintayin na may heart failure. Kahit na wala pang heart failure, wala pang umpisa ng atherosclerosis, umpisa pa lang, control the sugar, control the blood pressure with the appropriate medications that will not harm the sugar control. And when you give the anti-diabetic at anti-hyperglycemic agent na hindi makakasira ng kidney, okay, so the end organs, we have to protect them, whatever medicine, and then no interaction between among the medications. So we have to start early. Prevention. Kung meron
Yes.
na, mahirap nang balikan. Pag mahirap nang balikan. Pero ang mga pasyente natin, kahit kadalasan walang nararamdaman, ayaw mag-control. Okay, ayaw mag-control. Akala nila, sige-sige lang. Andiyan na, natatakot na pag may kidney na, pag na-heart attack na, doon lang sila bumabait. Pero yun lahat. Tapos yung early check-up, yung turo natin palagi, huwag niyo kalimutan, urinalysis for proteinuria during their first visit, eye examination for retinopathy, because the early stages, you can actually reverse it and prevent it from, there are so many medicine that you may use to prevent its progression if there is present, but early. Pero kung kailangan na lang ng laser, kailangan na ng intravitreal whatever, yung mga injection, sobra nang mahal nun, wala na tayong magagawa. We just prevent the organ damage na talaga. So ako talaga, mahilig ako yung slide na ginawa ni tatay, yung the macrovascular complication starts with insulin resistance pa, and the microvascular, and then we have to treat the primordial prevention of diabetes. Going that far.
Okay, so palakpakan po natin si Mama Grace. So lagi na lang,
Dani, oo.
napakahusay, napakagaling. Kaya manang-mana kami sa iyong lahat.
Ikaw na, magaling
So
ka.
thank you very much, ma'am.
Aral lang ng aral. Aral ng aral.
Opo, tama. Read
Walang
ng
katapusan
read.
mag-aaral.
Hindi kayo matatapos, ha? So agree sigurado kayo sa akin that indeed this is a very fruitful evening for all of us. At ito yung isang napakagandang simula sa bagong taon, 2022, kahit tayo po ay mga nasa virtual floor. Okay? So with that, we'd like to end this session. But before that, we would like to thank our partner and we would like to hear some words from them. So tawagin po natin si Sir Bern Ramos, CME Manager of your LRI Terra Pharma. And also we would like to thank nandito din si Ma'am Kathleen Salazar. Okay, Sir Bern, Ma'am Kathleen, you have the floor.
Thank you very much, Doc Danny, Dr. Grace. Maraming salamat po for that very comprehensive po na lecture na madali pong maintindihan, and at the same time, Doc Danny, for seamlessly moderating, Doctor, our webinar for tonight. First of all, Doctor, ako po would like to personally thank PSD for giving us this opportunity, no, na maging buena mano for January 2022. Bagong magkong Hey Pat Choy, happy Chinese New Year po sa inyong lahat, and maraming salamat po for the opportunity na maka-partner kayo ulit the start of the year, and of course for 2022 we will remain po as your katuwang na maaasahan po na partner pagdating po sa mga ganitong events and sa mga activities and projects po natin. Thank you very much po din sa oras po ng lahat po ng mga nandito. Kanina po, marami po natin mga doctors na nandito at nag-attend po din po sa ating weekend webinar for this January. Maraming salamat po sa oras po ninyo. And Ma'am Kat, baka po, I would like to introduce po the product manager of Candes and Candes Plus, si Ma'am Kat Salazar. Ma'am Kat?
Hello, good evening, Ma'am Kat.
Wala po siya. Ma'am Kat, wala ka audio? Wala pong audio. I-ano ko, Doktor? I-lip read.
Sige, i-sign
I-lip read
language
ko.
natin.
Thank you,
Ayan.
sa support niya sa PSD. Thank you.
Dr. Grace,
Thank you.
welcome po. Welcome, and likewise, maraming salamat. Ayan, mukhang nag-ano si Ma'am Kat ng headset na. And while she is fixing her her audio or attaching the file. And Doktora, ma-promote kami siyempre nung Candes pa rin natin 36 hours of superior BP control. At the same time, dear doctors, yung natutunan namin bago ngayong gabi, 40% reduction in diabetes, the DM retinopathy. At idadagdag po daw namin yan sa aming mga detailing, Doktor.
Yes,
And Doc.
Lord.
Ayan na si Ma'am Kat.
Okay na. Thank you so much, Dr. Grace, Dr. Danny, for moderating, and for your lecture po, Dr. Grace. Napakarami naming natutunan. Sabi ko nga, ang ganda nung naging discussion, and ang dami naming bagong learnings na pwede naming i-share, no, sa mga ating mga field, no, para ma-communicate din nila pag nag-detail sila. Napakaganda pong discussion. Salamat po sa inyong time, lahat po nang nag-attend tonight, even if it's a weekend po. So magandang gabi po sa inyong lahat. Thank you, Sir Bern, for everything, for facilitating po ating lecture for tonight. Dr. Danny, thank you so much for your
Thank you,
moderation.
Tim. Okay, kindly open your cam. Pwede tayong mag-picture,
Oo
o kaya
nga,
pwede
picture
pa tayong
tayo.
magkwentuhan. So, tingnan po natin kung anong nabago after New Year.
Kung tumaba o hindi.
Yeah. Gumanda. Si Ate Leyden gumanda.
Siyempre, may nagpapaganda. Wala na
Hindi
si
ko
Ate Lady.
alam. So, lastly, don't forget po, yung monthly itong ating PSD Select. So, we'll see you
topic?
again next month.
Anong next topic?
Okay. Ayan, hindi ko masyadong memorize pa, ma'am. So, February 26, we will update you sa ating Viber. Okay? So,